All right, good afternoon and good evening, everyone, depending on where you're dialed in from. Thanks for joining us today for this webinar, Illuminating Tumor Biology, New MammaPrint and BluePrint Insights from SABCS 2024 to Optimize Breast Cancer Care. We have a great panel of medical oncologists today with Dr. Joyce O'Shaughnessy, Dr. Adam Brufsky, and Dr. William Audeh. During this live webinar, they will all present the latest data from MammaPrint and BluePrint that was just presented last month at SABCS. And if you do have any questions, you can submit them at the top using the Q&A question button. And at the end of the webinar, should we have time, we'll address them. And since Dr. O'Shaughnessy has to get back to clinic after this, after she reviews her data, feel free to ask any questions specific to her presentation. Before I hand it over to Dr. Audeh, I'll just give a brief introduction to each of our presenters. So Dr. O'Shaughnessy is a board certified medical oncologist and a director of breast cancer research at Baylor Charles A. Sammons Cancer Center and chair of the Breast Disease Committee for Sarah Cannon Research Institute in Dallas, Texas. She's also founded the School of Breast Oncology, which is a curriculum-based program for medical, radiation, and surgical oncologists that aims to reinforce and expand their knowledge and expertise in breast cancer diagnosis, treatment, and management. And finally, since 2023, Dr. O'Shaughnessy is also the national principal investigator for the FLEX registry study, which to date has enrolled over 18,000 patients with breast cancer in a real-world, large-scale prospective observational breast cancer study. Dr. Brufsky is a board-certified medical oncologist and professor of medicine at the University of Pittsburgh School of Medicine. He is also the director emeritus of Comprehensive Breast Cancer Center and medical director of the Women's Cancer Center at the UPMC Magee Women's Hospital in Pittsburgh, Pennsylvania. He also serves as associate director for strategic initiatives for the UPMC Hillman Cancer Center in Pittsburgh. And he has authored or co-authored more than 300 abstracts and research articles in leading journals, and is also a principal investigator on several research grants funded by National Institutes of Health, Komen, and the U.S. Army Breast Cancer Research Program. Dr. William Audeh is the Chief Medical Officer at Agendia and is also a board-certified medical oncologist specializing in breast cancer with nearly 30 years of experience as a clinician and clinical researcher at the Cedars-Sinai Cancer Center in LA, where he served as the former director of the Cedars-Sinai Cancer Center and medical director of the Wasserman Breast Cancer Risk Reduction Program. And he has also been the principal investigator on a wide variety of national and international clinical and translational trials, and has authored numerous publications in the field of breast cancer, cancer genomics, and targeted cancer therapy. So with that, I'll hand it over to you, Dr. Audeh, and we can get started.
Thank you very much, Karen, and thank you all for joining us today. Here's the agenda for what we will be reviewing, and I want to preface this presentation by pointing out that all of these presentations derive from data from our FLEX registry database, which I'll describe a little later. And they really highlight the fact that MammaPrint and BluePrint are really providing answers to a variety of clinically relevant and important questions for women with newly diagnosed breast cancer. As you will see in the range of topics covered by these presentations and abstracts of neoadjuvant therapy, locally advanced disease, chemo prediction, and preliminary data looking at for biomarkers for CDK4/6 inhibitor effectiveness, all of which can be derived, I think, from the valuable information obtained from the 150 genes analyzed with MammaPrint and BluePrint. So with that, I will begin with the first presentation. MammaPrint and BluePrint predict pathological response to neoadjuvant chemotherapy in patients with hormone-positive, HER2-negative early-stage breast cancer enrolled in the FLEX registry. This was selected as a spotlight poster presentation, and I will hand this over to Dr. O'Shaughnessy to describe the study.
Thank you. Thank you very much. Thanks for tuning in, everybody. Today I'm impressed. Five abstracts at San Antonio from the Flex trial. That's pretty impressive. That's really great. It's up to 18,000 of a planned 30,000 to be enrolled and followed over 10 years. Full transcriptome. Amazing, amazing resource. It's only going to get stronger and stronger over time. A fabulous resource for our country. So this is to look at MammaPrint and BluePrint to really understand which of the subtypes of breast cancer that are HR positive, HER2 negative really benefit substantially from chemotherapy as measured by their surgical response at the time of surgery, their pathologic response. So next, please. So this is the poster. I'm going to break this down. This has been broken down into slides, but that's what it looked like. You'll have the whole thing there. So as we know, patients with HR positive, HER2 negative breast cancer, pathologic complete response to neoadjuvant chemotherapy is very, very low. And when we see a patient who's locally advanced, or even she wants cytoreduction because she wants breast conservation, and she's HR positive, HER2 negative, it's actually quite the dilemma to know what to do for those patients. Are they going to benefit from chemotherapy? Or if you really want cytoreduction, should they get endocrine therapy, perhaps with a CDK4/6 inhibitor? So that's why it's really helpful to see these data and just kind of see. Now this, we're looking here at pathologic complete response or residual cancer burden 1. So we're talking here about major responses to therapy. So we're not really looking at RCB 2, 3, and 4, although in the future we will be RCB 2 and 3. Now there is no 4. We'll be able to do that in the future to really have a feeling for, is it even worth it at all giving chemotherapy? So the endpoint here we're looking at is pathologic complete response and residual cancer burden 0, as I'll tell you. So we know from the NBreast trial and the I-SPY 2 trials, they've reported that MammaPrint and BluePrint can more accurately identify which patients are more likely to achieve a pathologic complete response with chemotherapy preoperatively compared to clinical risk alone, meaning nodal status, tumor size, and grade, for example, among the HR positive, HER2 negative. So we've seen these data before that I'll show you, that the NBreast and the I-SPY 2 have set the stage for this analysis now to go to this real world evidence large database across the country to see if these preliminary data or early data from NBreast and I-SPY 2 really hold up. So the recent data from the FLEX trial that actually was presented at ASCO this past year from the FLEX also showed an increase in chemosensitivity for patients with MammaPrint high 2 risk, so the ultra high risk patients. And we had seen some evidence actually that anthracyclines in the high 2 patients, an ACT-like regimen, had a higher pathologic complete response rate in the high 2 patients, and whereas a TC, a non-anthracycline preoperative therapy, really didn't have a very high path CR rate at all in high 2. So high 2 has already been called out in the I-SPY 2, but also in our FLEX trial, it's already been called out as predicting for higher chemotherapy sensitivity and from benefit from an anthracycline. Actually, at ASCO, I showed 3-year recurrence-free survival data from FLEX looking at an ACT versus TC regimen. No difference in the high 1s, but in the high 2 population, the TC was inferior and the ACT did much better. Now, these are not randomized data, only 3 years of follow-up, so we need much longer follow-up, but it really suggested that the high 2 population really benefited from the anthracycline. It was last San Antonio that from our FLEX data, we looked at preoperative ACT versus TC preoperatively and showed in the high 2 that the patients really benefited from the anthracycline. So next, please. Oh dear, my thing just went into a Teams. Okay, here we go. So here's the methodology. So the patients were all in the FLEX trial, consented for the FLEX trial. They were HR positive, HER2 negative, early breast cancer patients who the patient and the physician had decided to treat with neoadjuvant chemotherapy. So, and they had their pathologic data was available, whether they had a PAF-CR or not, and also or the residual cancer burden data that actually gets read, as you know, in the pathology report. So there are 457 patients. And so you can see in the table in the middle there, the MammaPrint and BluePrint results. So with regard to MammaPrint, of those patients who got preoperative chemotherapy, only 44% were the luminal A low risk patients. The patients who received the chemotherapy were high 1 and high 2. So high risk patients. The high 1 patients were almost all luminal B. 6 of the high 1s were basal-like, BluePrint basal-like. And then the high 2 patients, it was 159 patients, and about 45% of those were basal-like, and 55% of those were luminal B type on BluePrint. So that's the group we have to look at pathologic complete response. So the main study endpoint was called pathologic response, and that was a combination of having either a PAF-CR, so a traditionally defined PAF-CR, no cancer in the breast, no cancer in the lymph nodes, or residual cancer burden 1, which, as you know, is a very minimal residual disease in the breast. And in ER-positive breast cancer, patients with RCB 0, which is a PAF-CR, and RCB 1, they do very, very well with subsequent endocrine therapy. So that's what we decided to look at as pathologic response, either a PAF-CR or a residual cancer burden 1. P-values less than 0.05 were considered significant. And next, please. So this looks at the patient characteristics, and the bullet points on the left really kind of summarize the key data in the table. So MammaPrint classification was 10% of the patients were low risk, high 1 was 56% of the patients, and high 2 were 34%. So in our entire FLEX registry, as at the time of the analysis here, there's more patients now. These are the patients with HR-positive, HER2-negative breast cancer who had preoperative therapy, and we had good pathologic results on them. So nearly 60% of the patients were node positive. Higher stage and higher grade cancers were more likely to be MammaPrint high risk. That doesn't surprise us. Most of the high 1 tumors were luminal B. 98% of the high 1 is luminal B. 2% were basal, whereas with regard to high 2, 45% were luminal B and 54% were basal. And then patients with high 2 tumors were generally treated with an anthracycline. Most of them got an ACT, but because these patients with high 2, some of them were coming back basal. In fact, 45%, 45% were coming, 54% were basal, were coming back basal. Some of the physicians added platinum to the chemotherapy. That's why it says anthracycline plus minus platinum. So we put those two together because these are the DNA damaging agents, which the hypothesis is patients with high 2 would particularly benefit from DNA damaging agents. So next, please. Here are the actual results. And again, the endpoint here is pathologic response. And what we're seeing in the bar graphs here is the solid part is the PAF-CR rate, so no cancer in the breast or lymph nodes. And then the hashed part of the bars are those with residual cancer burden 1. So you can see that most of the patients who had a pathologic response, most of them had a pathologic complete response, traditionally defined. There was a small percentage of patients, less than 10% in each of these groups that had residual cancer burden 1. So if we start over on the left, we see that with regard to the low risk luminal A patients, only 44 patients, 4.5% had a pathologic response. They were all PAF-CRs. And then going over the high 1 luminal B patients, 242 patients, 7.4% had a PAF-CR and 2.1% had residual cancer burden 1. with regard to the high 2 patients, so putting the luminal and the basal high 2 patients together, the pathologic response was 32.7%, 28.3% of that was a PAF-CR. But then if we break the high 2s down into luminal B versus basal, like we see that the luminal B patients, 21.4% had PAF-CR or residual cancer burden 1, and the high 2 basal patients had 43.4% pathologic response. 39.8% of that was a PAF-CR. So this is similar to what we had shown at San Antonio in 2023. It's just larger numbers of patients, and we had shown that the anthracycline particularly benefited the high 2 patients. But we can see here that these patients with the low risk disease or even high 1 luminal B patients, they don't get very much in the way of substantial cytoreduction from the chemotherapy. That's not to say they might not get a partial response, but they're certainly not getting very substantial reduction. And then the luminal B high 2s, about 21% of those patients will benefit a lot. And then with regard to the high 2 basals, almost half of the patients will benefit a lot. So next, please. We decided to look at nodal status. Did nodal status really make a big impact on the pathologic response of these patients? And the solid colors are the lymph node negative, and the checkered is the lymph node positive. So if we start again over on the left with the luminal A, we see that in the node positive group, there were 4.5% of patients who had a pathologic response. The high risk 1 luminal B patients, there wasn't a lot of difference there, a very, very minor difference between a node negative and a node positive in terms of that pathologic response from chemotherapy. And then with the high 2 luminal B, there's a numeric difference there with the node negative patients getting 21% versus 9.4%, but the numbers are small, you see there, and it's not significant. And then as we get into the high 2 basal, there's really no difference, 41% with the node negative and 36.4% with the node positive, nothing significant. So it really doesn't seem, at least statistically at this time, that node status per se is really driving the opportunity for the patients to get a real good pathologic response. Next, please. So there was a multivariate analysis performed to really see which of the clinical and genomic factors really was associated with getting a pathologic response. And you can see, if you look at the odds ratio in the table, you can see high 1 versus high 2. So you can see with the high 2, there was a statistically significant, you see the p-value over on the right, 0.003, significantly higher chance, odds ratio of getting a pathologic response in patients that are high 2 compared to high 1. You can see if you look down the right of the table at the p-values, there's no other significant p-value. So in the multivariable analysis, it really was just the high 2 that was significantly predicting for pathologic response. You can see that, like tumor stage, for example, T1, T2, and T3, T4, really no difference, hovering around 1. The lymph node positive patients at the odds ratio of 0.65, so a somewhat lower chance of getting a pathologic response. Grade 3, that was a twofold increased possibility of getting a pathologic response, but it wasn't significant. And then TC versus an ACT plus minus platinum regimen, also in this entire population, putting the patients together, did not predict for pathologic response. So basically, over on the right, menopausal status, T stage, nodal stage, grade, and chemotherapy regimen did not significantly predict for a PAF-CR or pathologic response. It was just the MammaPrint high 2 here that significantly predicted. So next, please. So in conclusion, the MammaPrint and BluePrint predict for sensitivity to neoadjuvant chemotherapy in the HR positive, HER2 negative early breast cancer patients. And patients with the high 2 MammaPrint high 2, including luminal B and basal-like subsets within that high 2, are more likely to have a path CR or path CR with or residual cancer burden 1, which is the pathologic response, compared to the low risk and the high 1 patients. So these data suggest that the high 2 patients identifies a group of the HR positive HER2 negative cancers with the highest sensitivity, which therefore may be most likely to really enable downstaging and improve overall outcomes for patients, because the cancer is most sensitive to the high 2 cancers. So the treatment with an anthracycline did not independently predict for pathologic response or path-CR across all of the subtypes. But as I mentioned, prior studies, including from Flex, have shown that anthracycline therapy increased path-CR rates in high 2, but not high 1 disease. And I showed at ASCO this year, as I mentioned, that it was the high 2 patients that really needed the ACT. They didn't do as well with the TC, not randomized data. But it turns out that the ACT patients in Flex, as you would expect, are a considerably higher risk population. As you'd expect, patients and physicians making a decision for TC in the community will not be as high a risk in general as the ACT. So they're a higher risk population, yet they benefited substantially more from the ACT with regard to 3-year recurrence-free survival. So that's a really emerging hypothesis that's of great interest, that we will look forward to having more patients and more analysis from the Flex trial. So thank you very much. Happy to answer some questions here.
Thank you, Dr. O'Shaughnessy. Yes, if anyone has questions, you can put them in the question chat functionality and we can address them. At this time, there aren't any right now, but if any pop up before you have to leave, we'll address it. Otherwise, we can follow up with you.
Sounds good. Great. Thank you.
Thank you.
All right, then. Thank you so much, Dr. O'Shaughnessy, for reviewing that really important data, really indicating that of all the different variables that may be identified in a newly diagnosed breast cancer patient, that it's the genomic profile of high 2 that is most predictive of pathologic response in this hormone-positive population. And continuing on the theme of the use of genomics in the neoadjuvant setting, this abstract addressed the issue of locally advanced breast cancer of all subtypes, with the conclusion, as the lead author, Dr. Rahman, pointed out, that biology is still king. The lead author here, Dr. Rahman from Texas Tech University at the time. Here's the poster. And the point of this was to address the challenge of locally advanced breast cancer. We all know that it is a problem due to the challenge of trying to achieve not only a cure, of course, but a cosmetically acceptable breast conservation, which has led NCCN and ASCO to recommend consideration of neoadjuvant chemotherapy for these patients based upon the T stage rather than any other biological aspect of the tumor. We also know, as you've seen now from Dr. O'Shaughnessy's presentation and many other data that have been presented, that MammaPrint and BluePrint genomic signatures are quite accurate in predicting chemotherapy response, particularly in hormone-positive breast cancer. And this opens the potential for using genomic profiling in this challenging subset of patients to enable informed treatment choices and potentially reduce toxicity for patients who, despite having locally advanced disease, are unlikely to benefit from chemotherapy. So the point of this study was to examine the utility of MammaPrint and BluePrint for identifying clinical T3 tumors that do or do not respond to neoadjuvant chemotherapy. Our methods here involved a pooled analysis of patients from the NBREAST trial, a neoadjuvant study, the FLEX study, as you just heard from Dr. O'Shaughnessy, and another neoadjuvant study referred to as MINT, all of which have been presented previously in multiple abstracts. These trials did include patients with clinical T3 disease who received neoadjuvant chemotherapy. And so the total that we looked at with pathologic complete response as the endpoint was 404 patients, 67 from MINT, 214 from NBREAST, and 123 from FLEX. Here are the patient characteristics, and I want to point out a few important features here. The mean age, of course, not surprisingly, 52. When we look at the distribution, it's nearly half pre versus post-menopausal, although the majority of patients are white here, 73%, over 16% were Black, and in terms of pathology, 80% invasive ductal, 12% invasive lobular. The majority of these patients in terms of nodal status had N1 disease, 59%. And in reviewing the overall receptor status, I'd like to point out that 52% of these patients were hormone positive and HER2 negative, and they're the real focus of this analysis, because we do know that for HER2 positive and triple negative breast cancer, neoadjuvant therapy is considered the standard of care, particularly for any T2 or above tumors. Importantly, in this large cohort of clinically T3 tumors, 16% were genomically low risk by MammaPrint, and luminal A, therefore, when BluePrint was included. In looking at multivariate analysis, again, as we did in the previous abstract, of the factors which are predictive for a pathologic complete response, not surprisingly, the highest odds ratios for PCR were in the basal type of breast cancer and the HER2 type, because we know that they are quite responsive to neoadjuvant therapy. And this is in comparison to a relatively low likelihood of PCR in luminal type patients. In fact, the only clinical subtype of hormone positive patients that did show an increased likelihood of PCR were those that were triple positive, in other words, also HER2 positive. Here's a so-called Sankey plot of the percentage of pathologic complete response achieved in these various groups identified either by immunohistochemical subtype on the left or genomic subtype, BluePrint and MammaPrint, on the right. The most important feature here is that 52% of the patients were hormone positive and HER2 negative by immunohistochemistry, and of these, 29% were BluePrint luminal A, meaning luminal by BluePrint and low risk by MammaPrint. You can see of those 64 patients, 16.4%, 0 achieved a pathologic complete response. When we looked at PCR rates by nodal status, of course, that was unaffected by nodal status. The likelihood of achieving a PCR for hormone-positive patients was the same, with whether nodes were positive or negative. The likelihood was really predicted by the genomic subtype of low risk versus high risk, with an approximately 8.3 to 9.3% likelihood of PCR in high-risk patients and 0 likelihood in low-risk patients. So these data suggest that patients with MammaPrint low-risk genomic profile, all of whom are luminal A, if they're clinically T3, they are unlikely to achieve a PCR with neoadjuvant chemotherapy. And as we have seen from the prior studies as well, they appear unlikely to achieve a significant clinical benefit from neoadjuvant clinical chemotherapy. In fact, these data are in alignment with what we've already seen from the MINDAC trial, in that MammaPrint low-risk hormone-positive HER2-negative patients do quite well without chemotherapy. Of course, in MINDAC, these were stage 1 and 2 patients, regardless of nodal involvement. However, it corresponds with what we saw in MINDAC, that even clinically T3 tumors, if their MammaPrint low risk and luminal A appear unlikely to significantly benefit from neoadjuvant chemotherapy, arguing that this is a group for which newer agents or perhaps neoadjuvant endocrine therapy combined with other agents to downstage may be the preferred approach as opposed to neoadjuvant chemotherapy. Now I'd like to move on to briefly review the FLEX study itself. In the majority of recent meetings, we have always submitted a trials in progress update of the status of the FLEX trial. And in this case, our principal and author was Dr. Robert Maganini from St. Alexius Breast Cancer Center in Illinois. You've heard a lot about FLEX. Here's the overall poster. But the background for this study is clear. This is a real-world evidence database, which is necessary because, unfortunately, breast cancer remains the leading cause of cancer death among women, with nearly 15.5% of new cases in the U.S. This underscores the need to better understand tumor heterogeneity based upon our ability to analyze gene expression profiling in these tumors, particularly hormone-positive, HER2-negative breast cancer. So the design here is to seek full genomic data in the form of whole transcriptome data in every patient enrolled in the FLEX trial who is also undergoing MammaPrint and BluePrint standard of care testing. Our goal is to identify new prognostic and predictive gene signatures while enhancing trial enrollment among patients of racial and ethnic minorities who have traditionally been underrepresented in genomic studies. Also, this study encourages investigator-initiated sub-studies, as we call them, addressing a variety of unresolved questions in early breast cancer management in a cohort with 5 to 10 years of follow-up planned. FLEX is a large multi-center observational trial enrolling patients with breast cancer stage 1 to 3, male or female, over 18 years of age. We have at least 95 sites in the US now open, with several more to be opened. A plan for a total of 4 sites in Canada, 1 site open in Greece and 1 in Israel, and others to be opened as well. FLEX has enrolled, as of now, over 18,000 early breast cancer patients, all of whom have whole transcriptome data annotated with extensive clinical data, as well as MammaPrint and BluePrint. To focus again on our questions regarding racial and ethnic disparities in outcomes in breast cancer and underrepresentation in clinical trials, we have undertaken a concerted effort to include women of all self-reported races, including now over 1,400 Black women, over 530 Latin American women, over 350 Asian and Pacific Islander women out of what at the time was 14,000 early breast cancer patients. These numbers are increasing all the time and have allowed us to present significant data, particularly in the population of Black women with hormone-positive breast cancer. The trial is currently supporting 42 active investigator-initiated sub-studies. We have presented over 45 abstracts internationally, both at ASCO, San Antonio, ASBRS, Miami Breast, as well as ESMO and St. Gallen. This is the schema where any patient undergoing MammaPrint and BluePrint who meets the stage 1 to 3 breast cancer eligibility, as I mentioned, and does not have metastatic or recurrent disease can be enrolled with full transcriptome data being obtained at the same time that we obtain MammaPrint and BluePrint results with multiple sub-studies. We have Dr. Joyce O'Shaughnessy as our principal investigator of the study, and you've seen these numbers here, so I will not labor them any further. Many of our sub-studies and abstracts are now in manuscript and have been or will soon be published. Here's a map extending throughout the United States, but we are always looking for new flex sites. And I will proceed actually to hand things over to Dr. Brufsky for the remaining two very important abstracts. All yours, Dr.
Great.
Brufsky.
Thanks a lot, Dr. Audeh. And you're going to control the slides, correct?
I
From
am.
your end?
Yes,
Okay.
you tell me when.
Got it. Good. Great. So, I'm going to kind of finish up, and both of these actually come from Flex. And I think that the idea here is that we're really going beyond just the chemo, no chemo questions with these tests. They were originally designed, as everybody knows, to really determine whether we need to use, whether chemotherapy is of benefit or not. And I think that, to be able to extend this data to other questions, I think is really, really important. And some of the power of Flex, which really is, as Dr. Audeh just said, one of the largest, if not the largest, observational database of its kind. So we presented this at San Antonio this year, and its prediction of chemotherapy benefit by MammaPrint in hormone receptor positive, HER2 negative early stage breast cancer revealed by the Flex registry. I'm going to go to the next slide. This is just as the poster, and I'm going to go through the slides of it in detail. Next slide. So again, I think that the way we've had this debate that's been ongoing, and I think, to be perfectly honest with you, is semantic more than anything. I think that clearly NCCN and most of the other guidelines committees in Europe, as well as around the world, have accepted the fact that we have multiple assays that we can use to determine chemotherapy benefit and personalized chemotherapy benefit in patients with hormone receptor positive, HER2 negative, early stage breast cancer. And the MammaPrint signature can determine distant recurrence, and the MIND-ACT trial clearly showed that in genomically low-risk tumors, chemotherapy really was not needed for a substantial distant disease-free survival benefit now at 8 years, 8.7 years of follow-up at the last publication of the trial in 2021. And so really we have the Flex database to help us kind of fill in the gaps on that randomized clinical trial. In particular, one thing we were very interested in is trying to actually use the MammaPrint score as a continuous variable. And I think that's important in that I think women always ask the question when you do a MammaPrint, if it's very close to the binary cutoff, what the absolute benefit is. And that was the genesis of a lot of this. And I think we looked at the Flex registry, and we looked at patients diagnosed between 2017 and 2020 with at least 5 years of follow-up. Next slide, please. So we had 1,000 women with hormone receptor positive, HER2 negative early breast cancer treated either with endocrine therapy only or endocrine and chemotherapy. The median follow-up was 5 years. Now what we did, and this is important because this is just generally important as we get more and more into observational studies and they become more and more part of the oncology landscape. I think one thing that's important when you look at an observational trial is to see how bias is controlled. And one way we do this is by what's called propensity score matching. We try to match both groups as closely as possible in terms of their baseline characteristics to be sure that it's almost like a pseudo trial, even though it's not randomization, and the statistician will tell us it's not randomization. Still, we try to match it, the control, both groups, the test groups that we're looking at, as closely as possible. And the primary endpoint was distant recurrence-free interval, which is defined as the time from diagnosis to distant recurrence or breast cancer-specific death. And as you can see here, the patients were propensity score matched by menopausal status, tumor stage, nodal status, and there are about 500 per arm in the endocrine therapy only and the endocrine and chemotherapy arms of this study. Next slide. So these are the clinical characteristics of the patients. I mean, they're typical of, I think, what we would see in a clinical practice. The mean age was about 60, a little under 60, about a quarter, a little more than a quarter with 30% were premenopausal, There was a little less representation of the black population than I think we would have liked. It's about, anywhere, on about 9% overall in the study. Tumor stage is a typical distribution that we would see. It's mostly T1, T2. About a quarter were positive for extra lymph nodes. And again, you had to be N1, you couldn't be N2 in this particular analysis. And the one thing we could not match for was grade. We could not control for tumor grade in this, despite attempting to, because it was statistically significantly higher in the endocrine and chemotherapy group of this study. Next slide. So this shows you now the MammaPrint as a continuous variable with and that's the darkest line. Endocrine therapy only is the blue, the solid blue. Endocrine and chemo is the red, and you can see the 95% confidence intervals. And I think that, as you can see, the MammaPrint index was strongly predictive of the 5-year distant relapse-free interval event, both in the endocrine only and the endocrine and chemotherapy arms. And the risk differences increased as the MammaPrint risk score became more negative or increased. It's kind of counterintuitive, but it's a higher risk score with a more negative number. And you can see here the average risk, both for ultra low. This is the the differential risk. I think if you look at the table on top, the differential risk for ultra low was 0.6%, for low 1.7%, for high 1 about 5%, and for high 2 a little under 11%. Next slide. And I think this is important because we're looking now in a multivariate analysis of all the variables that looked at chemotherapy benefit. And in fact, MammaPrint index was the most significantly associated element. Both MammaPrint index and menopausal status were the most significant variables. Both were statistically significant on interaction p-values in this multivariate analysis, as opposed to everything else. Age was not significant. Tumor size was not significant for chemotherapy benefit. Lymph node status was not significant. Even tumor grade 1 versus 2, grade 1 versus 3, was not significant. So I think that this hopefully will put to rest the concept that chemotherapy, that MammaPrint is not chemo-predictive. It clearly is predictive of chemotherapy benefit in this observational controlled analysis. Next slide. And one question that we had when this happened is that if you look carefully at the index, there did seem to be some chemotherapy benefit for some of the lower kind of, if you look around like maybe -1 to about 0.1, 0.2, there was a slight benefit to the chemotherapy and endocrine therapy over endocrine therapy alone. And I think this could probably be explained by the higher number of premenopausal patients in that kind of borderline area. And in fact, what was probably happening here, what we believe is happening here, is that the chemotherapy was serving as ovarian suppression. And that's why there was chemotherapy benefit. And you can see the distribution of the MammaPrint index. You can see +1, +2, 0.2, 0.01, 0.02. You can actually see a substantial number of pre- and perimenopausal women. Next slide. So I think that clearly the patients with increasing MammaPrint risk, that is a more negative score, the higher the score, had a significantly lower risk of disease-free interval, distant relapse-free interval events when treated with chemo and endocrine therapy versus endocrine therapy alone. And this is consistent with MIND-ACT in that MammaPrint low and ultra-low patients in MIND-ACT, the randomized clinical trial, did not derive significant chemo benefit. Chemo benefit is not predicted by the higher tumor grade after adjusting for MammaPrint index and other clinical factors. And I think the observed chemo benefit in the premenopausal patients with MammaPrint low is likely, I think but I believe probably likely due to ovarian function suppression. And again, I think that these real-world data confirm that MammaPrint really is prognostic of recurrence risk and clearly predictive of chemotherapy benefit in patients with hormone receptor positive, HER2 negative, early stage breast cancer. Okay, I think I'll go on to the next presentation after this. So I think, the idea here, again, is the beauty of Flex and the beauty of having 18,000 patients, all of whom have had whole transcriptome, all of whom have actually a photomicrograph as part of Flex, all of whom have, or, at some point are going to have at least 5 years of follow-up data. I think we estimate about 200 to 300 women a month actually hit the 5-year mark now. So this is increasing, by a couple thousand per year, are going to hit that 5-year follow-up mark. The beauty of this and having the whole transcriptome allows us to go back and begin to test hypotheses that may actually at some point become clinically relevant and clinically applicable. And I think one of the biggest issues, one of the major issues we're having in early stage breast cancer and breast cancer in general, and given that breast cancer is a third of all oncology, medical oncology in this country, I think that it's important for oncology in general. And that is really what to do about CDK4/6 inhibitors. They clearly have benefit in the metastatic setting. They have changed the natural history of the disease, and we're now starting to use them in early stage breast cancer. And we have 3 trials that I think everybody is aware of. PALLAS with palbociclib, which was negative. We had Monarch-E, which now has 5 years of follow-up data showing a clear distant relapse-free survival advantage. And now we have NATALEE, which also has a distant relapse-free survival advantage, was just recently approved by the US FDA. And importantly, approved for estrogen receptor positive, node negative breast cancer. That's at least T2 and above, with either grade 3 or high risk genomic testing, either by Oncotype or MammaPrint. And so this is a substantial number of patients that are now currently eligible for a CDK4/6 inhibitor with its attendant 3 years, in the case of Kisqali, 3 years of toxicity, as well as more expense, more copays to the patient. And so this is an area, I think, for a variety of reasons, not only scientific, because it would be very interesting to know hypothetically why our hypotheses of why some people benefit and some don't, and that potentially could be probed from looking at tumor microarrays and clinical data, but also clinically. I think that we always, as oncologists, have to decide the risk-benefit ratio of everything we do, and I think the risk-benefit ratio of CDK4/6 inhibitors, especially in node-negative disease, is really an open question. I think that obviously, some of the more recent data suggests about a 3 to 5% benefit in node-negative disease in terms of at least 4-year relapse-free survival. But the issue is that this is really crying out for a biomarker. And so this is kind of, at least initial, this is not looking at the clinical trials yet, but this is actually what we did in this particular presentation, which was presented as a poster at San Antonio. What we did is we actually looked at some signatures that have been derived preclinically and applied them to the Flex database that we have. And there were 2 signatures that we looked at. This is just the poster. You can go on to the next slide. So again, just to to go back through here, CDK4/6 inhibitors obviously have recently been approved, as I said before, in the adjuvant setting for clinically high risk early stage breast cancer, and about 30% of advanced breast cancer is resistant to CDK4/6. We know that from the metastatic setting. So is that true in the adjuvant setting? We don't know yet, and we really don't have any biomarkers, and it's not for lack of trying, both in the metastatic and even adjuvant setting. We've tried every biomarker. The only biomarker that seems to be associated with CDK4/6 benefit right now is estrogen receptor status. And people have looked. I mean, there may be MYC maybe in the adjuvant setting, but really we don't know. And so we decided to take some of these signatures that have been derived preclinically and apply them to the Flex database to kind of see whether they correlate to any of the Flex subtypes. Next slide, please. So we took 5,657 patients in the Flex database who had early stage hormone receptor positive HER2 negative disease. And we tried to correlate the various MammaPrint risk groups, ultra low, low, high 1, and high 2, to 2 different genomic signatures or resistance signatures that have been developed. There's something called an RB-Sig genomic signature, which is 47 genes, which measures loss of function of RB and subsequent E2F dependent cell proliferation. So remember, CDK4/6 inhibitors inhibit the retinoblastoma protein from binding to E2F. And so it allows this, it stops the cell cycle. So if you have a high RB-Sig, you're likely to have palbociclib resistance or CDK4/6 resistance. We also looked at an 11 gene signature that was derived on another set of cell lines that are both sensitive and resistant to palbociclib, and it looked at phosphorylation of CDK4 in this to see whether, really directly, whether palbociclib, the cells were resistant to palbociclib or not. And so we looked at these two signatures and tested them out on the transcriptomes in the Flex database. Next slide. This just shows you this is typical of the kind of patients in Flex. The mean age was 60, about 3/4 were postmenopausal. The grade, the nodal status actually was distributed, and the grade was distributed as you'd expect. We had, again, looking at this, a fewer high 2s than I would have expected, about 13% of the entire database. Well, that's about right, about 13 to 15%. High 1s generally are about 35%, so about 50-50. High and low. Next slide, please. And this just shows you the RB-Sig here. Interesting, and it's not shown in this. About 7 or 8 of the genes in this RB-Sig 47 gene signature are actually in the 70 gene MammaPrint test. And there was a correlation observed with increasing MammaPrint risk and increasing RB-Sig scores, suggesting that the MammaPrint high 2s demonstrated the highest probability of loss of RB function and the highest probability of CDK4/6 resistance. Next slide. This just shows you actually a little bit better and more digestible form. You can see the mean gene expression of the RB loss signature seemed to be highest in the high 2s and highest in the high 2 basals. And again, I think this is consistent with what these high 2s are. These are very highly proliferative tumors that have increased DNA repair deficiency, have a lot of issues going on that may make them resistant, resistant to RB control. Next slide. So the other score that we looked at was an 11 gene score, and it's a very interesting score. It really measures preclinically in palbociclib sensitive and resistant cell lines the phosphorylation of CDK4, and you can see here that again there are 3 separate signatures that are, or 3 separate outcomes of the signature, and the resistance outcome of the signature is shown. The resistance signature is present in 43% of MammaPrint high 2s, where it's about 1.8% of high 1s and almost nothing in the low and ultra low. Next slide. So I think that what's interesting here is that at least when we apply these preclinical signatures to the Flex database, it appears that MammaPrint high 2s, at least half of them, may be resistant to CDK4/6 inhibition. And I think that, again, they're consistent with other studies that show that increasing MammaPrint index is closely associated with cyclin E expression and expression of genes on chromosome 8q224. MammaPrint high risk and high risk basals seem to have some sort of amplification of that chromosome subregion, which has cyclin E, metadherin, and T-SPY-L1 in it. And I think that this is another interesting kind of side note that may be correlating higher risk MammaPrint to CDK4/6 resistance. I think that the nice thing and the interesting thing about this, I think the question we presented this data actually was a poster discussion. And Matt Getz, the discussant, said, well, why don't we just simply look at an RB signature? Why are you looking at this? And the answer to that is quite simple. This is commercially available. It's here already. And really, all it's going to take is data generation from the existing randomized clinical trials like PALLAS, like NATALY, like Monarch E, and if you could apply the signature to some subset of those patients to see if it does actually predict for CDK4/6 resistance, we may have a commercially available signature. And I think that's where a lot of research, at least on our end, is going to try to figure out whether the existing MammaPrint signatures can predict for CDK4/6 resistance. So with that, I'll kind of turn it back to you, Bill.
Well, thank you, Adam, for that terrific review. And thank you all for participating in this webinar. I think I can summarize the data that we've just heard as the continued expansion of the utility of gene expression profiling with MammaPrint and BluePrint to answer a variety of questions, not simply which patients need chemotherapy or will benefit from chemotherapy, but also predicting responsiveness to neoadjuvant chemotherapy, and in the case of large, low-risk tumors, possibly reducing exposure to unnecessary chemotherapy, but also predicting the potential benefit of other therapies such as CDK4/6 inhibitors. And although we didn't review it here, Dr. O'Shaughnessy made reference to the data presented at ASCO, which also showed the utility of MammaPrint in predicting not only the potential benefit of anthracycline, but also the potential benefit of immunotherapy in hormone-positive breast cancer. So the future really involves using MammaPrint and BluePrint and gene expression profiling for more precise therapy selection to avoid unnecessary toxicity, but also to escalate therapy in high-risk patients who appear to need it. So with that, I'll stop sharing. And if there's any time for questions, we can certainly try to address those now.
Yeah, there was a question, Dr. Audeh, about the FLEX study, the FLEX registry, about the age of the patient population. The question was, why are there not older patients from 70 to 80? Is it following like the MIND Act enrollment or what?
Well, we do have older patients. Our only restriction was patients need to be over 18, but we do have older patients as well. So we, in fact, will be presenting data on patients over 70 as a specific cohort that we're analyzing. So no restrictions there.
Okay, great. And one more is a question about patients often requesting a specific number or percentage of chemo benefit. And the question was, is there a plan to document this more clearly on our report? So perhaps you touch on the updated reports that we just rolled out, and we can definitely follow up with this person as well.
Yes, absolutely. Thanks to Dr. Brufsky's presentation, we saw the chemopredictive data in the high-risk range of MammaPrint, something that wasn't really provided by prior studies such as MIND Act. So the data from those patients will be used to provide predictions of chemotherapy benefit as the MammaPrint index becomes more negative, because as you saw, the curves clearly separate quite significantly in the high-risk range between chemotherapy and endocrine therapy versus endocrine therapy alone. And the magnitude of benefit does increase as the MammaPrint index becomes more negative. I will also add, of course, that any of these genomic results needs to be placed into the clinical context of the patient in terms of what the overall clinical risk may be. And the genomic risk is really not only complementary, but perhaps adding some greater precision to predicting not only the risk of recurrence, but the likelihood of benefit of therapy.
Great. Well, perfect timing. We're right at time, so I want to be respectful of everyone's time. Again, thank you, Dr. Audeh. Thank you, Dr. Brufsky, and thank you to Dr. O'Shaughnessy, even though she had to step away. That was a great, very detailed presentation. This is recorded, so if you do want to, for those attendees, if you do want access to the recording, just email us at marketing@agendia.com and we'll make sure you get the recording to review again. And for those that had some other questions that we didn't have time to address, we will follow up with you and make sure you're in touch with your local Flex Agendia representative and get those questions answered for you. So with that, again, thank you very much to the attendees and our presenters. Appreciate it. And we look forward to seeing you on the next webinar. Thank you.
Thank you.